eyelid lesions, simple excisions, wedge resections, and more complex reconstructions for eyelid tumor and eyelid lesion excisions. We all see simple lesions in our office every day. Most of these can be excised within a few minutes. Local anesthesia, forceps, scissors, we excise the lesion. If it looks suspicious, I always send it to pathology. If it's just a simple papilloma, I do not always submit that for pathology. But if it looks suspicious or I need to know the pathology, I will put it in formalin and send it off. But these simple excisions often just require excision, very light cautery of the excision site, and often you do not even need any sutures. And I'll just show you some examples of some of the simple benign lesions that we see in ophthalmology. One of the most common is the squamous papilloma. Sometimes they're called a skin tag, or a fibroepithelial polyp, or acrocordon. They have many names, but they're benign squamous papillomas. And these have been associated with some systemic conditions, and if you see a patient with dozens or hundreds of squamous papillomas all over their face or all over their body, sometimes that is caused by HPV, human papillomavirus. And some of those patients are at an increased risk for squamous cell carcinoma later in life. But these are very common. In some studies, up to 50% of adult patients do have at least a few papillomas. So they're very common. They have a classic appearance. They're usually elongated. They have little tiny villus structures on them. If you look at them through a slit lamp microscope, they all look fairly characteristic. Some of them are very elongated and eventually can become ischemic and just fall off on their own. But these are the so-called squamous papillomas. When you see a cluster of many papillomas all over the eyelid, those patients are at a higher risk of carrying HPV, human papillomavirus. There are many different subtypes of HPV, and some of them are highly linked to papillomas. Other types of HPV are linked to cervical cancer, squamous cell carcinoma, and other conditions. But some of these can be larger and can be often observed in HPV, and also verruca vulgaris, a larger lesion, can be associated with HPV. Other lesions are called seborrheic keratoses. They sometimes are pigmented, sometimes they're not pigmented, but they tend to be flatter, and they're easily removed because after injecting a local anesthetic, you can often grasp the edge of it with forceps and use a 15 blade or a scalpel and gently peel them off of the skin. So they're usually pretty easily removed without much of a deep incision. Some of the seborrheic keratoses can be quite large and can become pigmented or necrotic, and sometimes can be confused with other lesions such as melanoma. And some patients have dozens or even hundreds of seborrheic keratoses all over their face and all over their body. And we usually don't remove all of them, we just remove the ones that are causing symptoms or cosmetically objectionable. Another common lesion is called a syringoma. They tend to be round or oval shaped. They come in clusters. You'll often see them on the medial lower lids and on the cheek area. And these are thought to arise from eccrine cells in sweat glands. They have a waxy appearance. They can be associated with some congenital syndromes. And I've seen some patients that have just a whole cluster of these syringomas covering a wide area on the lower lid. Now, if a patient has a broad area of these syringomas on the lower lid, you sometimes have to be cautious not to remove all of them at one time. If you do too many excisions at one time, then during the healing phase, there can be some contraction of that skin. Then they can get a cicatricial ectropion or even a lower lid retraction. So if a patient has multiple lesions like this all in one area, it's sometimes safer to remove a few at a time. Remove maybe 4 or 5 lesions, wait 3 months for that to completely heal, remove a few more, wait for a few months and remove a few more. That's a little safer than removing all of them at once to try to avoid tightening of the skin and ectropion. And some of these could be quite extensive and cover the upper and the lower lids. These are called syringomas. They're benign lesions. Another benign lesion that can be associated with a pox virus is called molluscum contagiosum. And this typically has an umbilicated structure with a pit or a hole in the center, and they're very classic in appearance, and they can shed a virus. Often when you remove these, it's best to excise them and lightly cauterize the face beneath them, and that will usually eliminate that lesion. It also decreases the shedding of the virus, so that decreases the chance of having more of these lesions in the future. These are various types of simple nevi. A nevus is a benign lesion that contains increased melanocytes. Some of these can later convert into melanomas, but that is rare. And some of these are benign congenital nevi. These do have a higher incidence of conversion into melanoma later in life. Dysplastic nevus with an irregular border or mixed colors or some strange ulcerations or bleeding or vascular changes. These are called dysplastic nevus, and they have a higher incidence of conversion into melanoma and should be excised. There are several vascular lesions of the eyelid. Most of these are capillary hemangiomas. Some of them are cavernous hemangiomas. I'll show you some examples of these. They can be elongated, they can be flat, they can be subcutaneous, they can be associated with congenital syndromes, such as Sturge-Weber syndrome. This patient had a very extensive Sturge-Weber syndrome with a big capillary hemangioma that extended up onto the scalp, across the brow, and down into the cheek area. He covered it with a cosmetic powder just to block the view of it, but he had this debulked in the past, and then I saw him, and it was causing a secondary ptosis, so we did some additional debulking and ptosis surgery to help with his drooping and his laxity of his upper lid. Another common lesion that is considered benign in most cases is an angiofibroma. These can be associated with a syndrome known as tuberous sclerosis, also with multiple endocrine neoplasia type 1. These could be excised and debulked when there are many of them. Often when there are this many, you can only remove a few at a time. Now, xanthelasmas are common in patients with hypertriglyceridemia, and they contain histiocytes that contain lipids. They can involve the upper lids or the lower lids or both. They're typically on the medial aspect of the eyelids, and they often will cause a yellow deposit on the medial aspect of the upper lid or the lower lid. And when we see a patient with this condition, we want to check their lipid profile, check their cholesterol and their triglycerides. It's actually more associated with hypertriglyceridemia than hypercholesterolemia, so make sure you check their triglycerides. There are many different types of cysts of the eyelids. Some of them arise from sweat glands or oil glands, sebaceous glands. So I'm going to show you some examples. These are chalasia and sebaceous cysts. And also, if it's right on the lid margin, we call it a sky or a hordeolum. And these are different types of sebaceous cysts. They arise from the glands of Moll on the lid margin, or if it's a chalasia, it arises from the meibomian gland. Pseudoriferous cysts arise from sweat glands or Moll glands. And they're also called hydrocystomas or cystadenomas. And these are very common. They sometimes are solitary with one cyst, and sometimes there are dozens of them. I've seen patients that have had as many as 60 of these cysts on all 4 of their eyelids. When it's just a few, I will inject local anesthesia in the office and remove it right in the office. If it's 50 or 60, then I will take them to the operating room and they'll have some intravenous sedation. But it's too painful to inject that many lesions without sedation. This patient had multiple pseudoriferous cysts or hydrocystomas across all 4 eyelids. This is a conjunctival inclusion cyst, and these can be large or small. I've actually seen these cysts that are mobile. They're subconjunctival, and they become isolated. And if you push them around with a Q-tip on the eye surface, they can actually move around in the subconjunctival space. So some of these are actually mobile and not attached to anything. Neurologic or neurogenic tumors include neurofibromas. We've seen 2 or 3 patients just in the last few days with neurofibromatosis, and they tend to get either massive tumors like this, or they can get more diffuse, soft, spongy tumor that infiltrates the eyelids and expands and stretches the eyelids. So these patients, as the patient on your left there, get severe laxity of the upper and lower lids. So they often require surgery to not only debulk the tumor, but to tighten the eyelids, sometimes to lift the lateral canthus, sometimes correct an ectropion or ptosis. But I've seen many patients with neurofibromatosis. These tumors are diffuse and infiltrate skin, dermis, muscle, orbit, all layers. So you really can't completely excise them. You have to just debulk them, reduce the amount of tumor tissue there, and address any ptosis or laxity of the eyelid. And they can be quite extensive. They can extend from the forehead, through the brow, through the upper and lower lid, and down into the cheek, and sometimes require a flap to debulk them. Actinic keratoses, also called solar keratoses, are considered a pre-malignant type of tumor. They often precede development into the squamous cell carcinoma. So if you see an actinic keratosis, it's usually caused by ultraviolet radiation and sunlight, causes damage to the skin, that will cause some ulceration and some crusting of the skin, and these can later turn into a squamous cell carcinoma, so it's best to excise them. A keratoacanthoma, or a cutaneous horn, is considered in transition between an actinic keratosis and squamous cell carcinoma. And these are now considered by ocular pathologists and dermatopathologists to be a very low-grade squamous cell carcinoma. So keratoacanthoma is now considered a low-grade squamous cell carcinoma and should be removed. Basal cell carcinoma is the most common one that I see in my practice of all of the skin cancers. It can become quite extensive and spread into the orbit and into the sinuses and into the skull, but it usually does not metastasize to other parts of the body. It can metastasize, but it's very, very rare to metastasize. Now, sometimes a basal cell carcinoma can be quite extensive. I saw this patient during my fellowship in oculoplastic surgery. He had received an exenteration of his right orbit 10 years earlier. Then he was lost to follow-up. He did not come back. Well, he finally came back, and this tumor had recurred, and it spread into the nose, into the ethmoid sinuses, and into the other orbit, into the skull base, and wrapped around the carotid arteries and the cavernous sinuses. So not at all resectable. And back when I saw this patient, the only treatment available really would be radiation therapy, and they're not very sensitive to radiation therapy. So this would be a terminal condition when it's growing into the skull base. Nowadays, we do have other options, and I'll show you some of those other options in a little bit. Another type of malignant tumor is squamous cell carcinoma. These tend to have a little bit different appearance and architecture than basal cell carcinomas. They can be more ulcerated, red. They can be invasive. They can cause pain in the face if they invade the nerves. They are known to travel to other parts of the body through perineural transmission. So you have to be cautious with squamous cell carcinomas. They can get into a nerve and travel along that nerve to another part of the face or the head. This is a patient I saw at the Veterans Hospital in Fort Wayne. He had undergone previous extensive excision of a massive squamous cell carcinoma, and then he had a pedicle flap taken from his back up to his face to cover part of the defect, and he had an orbital exenteration as well. So this patient is really a terminal patient. His life was extended a while just by doing heroic surgery. Sebaceous carcinoma, these arise from the oil glands, probably the meibomian glands and the glands of Zeiss of the eyelid. And in my country, sebaceous carcinomas have a very high mortality. Now, when I was in Bangladesh several years ago, working with a doctor in Chittagong, he said, we see a lot of sebaceous carcinoma here, and it has a low mortality. So they tend to have different behaviors in different parts of the world. This is a lentigo maligna, or basically a melanoma in situ in the surface layers of the skin. These should be fully excised because they can convert into a deep invasive melanoma. This is a Kaposi sarcoma. Back when the AIDS and HIV was much more prevalent, these tumors were commonly seen in patients with immune deficiency syndrome. Now we're going to talk about some of the procedures for excision of these larger tumors. We'll start with wedge resections. When you see a tumor like this that's involving the lid margin and you're in the operating room, you want to take a marking pen and mark at least 3 millimeters beyond all visible margins of the tumor, at least 3 millimeters. And then if you have pathology available to do a frozen section, that's a good way to manage the margins. With a frozen section, you send your specimen off, and while you're doing your reconstruction, the pathologist examines the margins, and they call you back within about 30 minutes and say, your margins are clear, go ahead and finish your surgery. Or they say, I need another specimen from the temporal margin, or the medial margin, or the inferior margin. So that gives you an ability in the operating room to try to make sure all of your margins are clear before you close up. Now, in my country, we have some dermatologists that specialize in Mohs, M-O-H-S surgery, and they use a different technique where in their office, they will go back and forth 5, 6, 7 times and take little slices of tissue again and again and again. They go back and look at them under the microscope. They're trained as dermatologists, dermatologic surgeons, and dermatopathologists. So they do the excision and the pathology themselves in their office. That's called a Mohs surgeon. And I see referrals from them sometimes after they've removed a big tumor. They'll put a bandage over it and send it to me to put it back together. And sometimes it's just a small defect. Sometimes it's the entire lid and the medial canthus and part of the cheek. So it depends on how much tissue they remove that will determine how much we have to reconstruct. But I'm going to talk to you about these larger excisions of larger tumors. You know what? The basal cell carcinoma, if they're nodular, they're easier to remove. If they're more diffuse, like this one, you know, this tumor extends way up into here. It's not always obvious how far the tumor extends, but after you see many of these, you can get an idea as to how far the tissue extends, and you always want to mark beyond that. You want to take the tumor, send it to pathology, and get some answers as to whether you've excised it all. Once you excise it all and you're sure your margins are clear, then you begin the reconstruction. This was a large tumor excision sent to me by a Mohs surgeon. He had excised this massive tumor involving lower lid, medial canthus, nose, and the cheek, and sent it to me for reconstruction. And I'll show you some slides a little later on the reconstruction. Now, what happens when a tumor is not resectable? This tumor is not resectable. It's growing into his skull base. It's around his carotid arteries, having his sinuses. It's in the other orbit. So your options are radiotherapy. It's not a very good option. It doesn't work very well for basal cell. And also there are some new drugs available that have been available since about 2012. And some people have even tried the antifungal drug, itraconazole, to have a suppressive mechanism on extensive or metastatic basal cell carcinoma. This drug first came out in 2012. It was very, very expensive. The price has come down a little bit, but it can be given for palliative treatment for patients with extensive basal cell carcinoma. And there are other drugs that are also biologic agents. These biologic agents are not chemotherapy. They are not chemotherapy. They are biologic agents. They are targeted antibody molecules that were engineered specifically for one specific biologic target. And these are called hedgehog inhibitors. They go to a specific pathway in the development of a basal cell carcinoma, and they block that pathway. So they're very targeted macromolecules, basically antibodies, that attack a very specific link, a site in the pathway to developing a basal cell carcinoma. And patients have to meet the criteria to get these very expensive drugs. It has to be a very large tumor, Patient that usually has had previous surgery and the tumor recurred, or the patient's not healthy enough to have extensive surgery. So once they meet the criteria, then sometimes the insurance company will pay for these. And it's quite impressive. Here's a patient with extensive invasive basal cell carcinoma, and then here's after about 6 months of treatment, and this is after 16 weeks of treatment, and you can see the progression of the tumor regressing from this drug being given, and it's given at intervals. And it's taken 1 capsule per day, and usually somewhere between 8 and 12 months. It's extremely expensive. It's come down a little bit, but it's still very expensive. There are a couple of other competitors, similar drugs, that have also been approved for basal cell carcinoma. And the one good thing about competition, when there are 2 or 3 or 4 different drugs available, that competition will sometimes start pushing the prices down a little bit. So it's good when there's more than one drug available. They do have some side effects, and some patients get enough side effects where they have to stop the medication. But the side effects are not as severe as we would see with standard chemotherapy. Now we'll talk about some reconstruction techniques after we'll go one by one. With simple excisions, often you can just excise the lesion, lightly cauterize the excision site so it doesn't bleed, put some ointment on it, and send the patient home, see them back in 6 weeks, and it'll be completely healed. No sutures. If it's a little bit larger, then we just do a simple closure. And be careful when you do closures near the lid margin, because during healing there is always contraction. And with contraction, if it's a large excision site, the contraction may cause eyelid retraction or lower lid superficial ectropion. So be cautious about the direction of your incision, the size of your incision. And sometimes in patients that are older, if I do an excision near the lower lid and they already have some lower lid laxity, I will sometimes do a lateral tarsal strip just to tighten the lower lid, knowing that if I don't tighten the lower lid, they will get ectropion later on. So sometimes I'll do a lateral tarsal strip just to try to prevent ectropion later. But with simple wedge resections, we do a full thickness excision if it's a tumor involving the full thickness of the eyelid. And we'll prepare the eyelid by first put in sutures to close the lid margins. I hold those together temporarily with hemostats. Then I close the tarsus layer and the muscle layer with 5-0 Vicryl. Then I will close the lid margin in the skin, usually with 6-0 silk. And sometimes you can, if it's too tight and you really can't get these margins to come together because it's too tight, you can do a lateral canthalisis and release the canthal tendon. That gives you enough mobility to bring it together without being too tight. So if you try to force an eyelid together and it's too tight, it will inevitably dehiss and open up again. And sometimes I've used periosteal flaps. If you don't have enough support to the posterior lamella here, you can create periosteal flap right on the lateral orbital ring periosteum. You keep it attached right here, and you swing that flap inward here, and you can actually attach it to the tarsus, and then you can cover that with either a skin graft or bring up a skin muscle flap. And you get a nice closure, and it's very well secured. Sometimes I will do what's called a Tenzel flap. Tenzel was named after a Dr. Richard Tenzel, University of Miami. And that's basically creating a curvilinear flap off on the side and swinging a skin muscle flap in this direction so this can meet up without too much tension. And that's a very nice procedure to have in your toolbox when you're reconstructing lower lids. And with that, we are basically relaxing and cutting the inferior cruce of the lateral canthal tendon to give us more laxity so the lower lid can be closed together. You can do this with the upper lid or the lower lid. You can combine that Tenzel flap with the periosteal flap to support it and better reinforce it. Now the Hughes procedure is one of my favorite procedures. It's when you have a large defect of more than 50% of the lower lid. You can evert the upper lid. I used to put a traction suture through the upper lid, evert the upper lid, take a scalpel, and make a rectangular flap of conjunctiva and tarsus. And you keep it attached by Mueller's muscle and conjunctiva up beneath the eyelid. That way it still has a vascular supply while it's healing. And you bring that flap down into position and you suture it into place. It becomes the new posterior lamella of the reconstructed lower lid. Then you have to cover that with something for this front layer, the skin layer. So I usually put a skin graft on it, but you could also do a skin muscle, skin auricularis flap to cover it. And then we let that heal for about 6 weeks, sometimes even a little longer if it's an older patient in poor health. You want to make sure that flap has a good blood supply. Then you can later go back and do stage 2 of the Hughes procedure. In stage 2, all you're doing is anesthetizing this flap, and you're anesthetizing the flap, and then you're cutting the flap. You use some scissors to make sure your lid margin is nice and smooth, and you may want to excise that clump of excess tissue from behind the upper lid so it doesn't irritate the cornea. Now, this is called a same lid tarsoconjunctival flap. It's similar to a Hughes procedure, but you're using it to reconstruct the same lid. So you take tarsoconjunctiva from the medial upper lid and swing it over to the lateral upper lid. You can also do a free graft where you just take a free graft piece of tarsus and conjunctiva and move it to another part of the eyelid, cover that with a skin muscle flap. So that you can be creative with eyelid reconstructions. And once you have several of these techniques in your toolbox, you can combine them together in different ways to handle almost any type of surgical defect. Now this is a Cutler beard procedure. It's kind of the opposite of a Hughes procedure. Hughes procedure, we're using upper flap to reconstruct the lower lid. Here you're using lower lid to reconstruct the upper lid. It's not quite as effective as a Hughes procedure because the tarsus is much smaller in the lower lid, so you don't have as much support and rigidity when you're doing a Cutler beard procedure. But still, it's effective. I used this a few years back when I was doing a similar trip in Phnom Penh. We removed a large melanoma, removed almost all of the upper lid, and we used a Cutler beard procedure to reconstruct the upper lid. And that has to be cut in about 6 to 8 weeks as well. There are various flap techniques, rotational flaps, sliding flaps, rhomboid flaps, different types of W plasties and Z plasties that can be used to reconstruct areas. And this is called the glabellar flap, where you take tissue of the central forehead and you rotate that down into position to reconstruct a medial canthal defect. This is often used for a medial canthal basal cell carcinoma. In a big tumor like this, you have to use a combination of different procedures to get it all back together. So in this patient, quite extensive, entire lower lid, all of the medial canthus, side of the nose, and a big part of the cheek. And I took out the gel foam, made sure all the tissue was negative, and then I did a large rotational cheek flap to cover the cheek defect. And then I brought down a glabellar flap to reconstruct the medial canthus area. And that really filled in the defect nicely. Just a very large rotational cheek flap and a glabellar flap. Now this was a young patient. This man was only in his 30s and had an extensive basal cell carcinoma. It was removed by a Mohs surgeon with a fairly extensive excision. And then he came to me for reconstruction. And he was young, so he did not have much skin on his upper lid. In older patients, we like to use the upper lid for a source for skin graft. He was young and did not have enough skin on the upper lids, so you can take it from behind the ear, retroauricular, or above the collarbone, supraclavicular. So we took a supraclavicular skin graft and sewed that into place. Now, supraclavicular skin is a little thicker than upper lid skin, but it works very nicely as a skin source for periorbital, periocular skin grafts. Now, this patient was sent to me after our Mohs surgeon excised a large tumor, and he just put a temporary stitch there to hold the eyelid up into position to cover the eye. Then the patient came to me, we opened it all up. We rebuilt this defect with a combination of a Hughes flap to reconstruct the lower lid posterior lamella. And then after the Hughes flap was pulled down into position, I began to cover that plus the other defects with a combination of multiple full-thickness skin grafts. This was an older patient, so he had a lot of excess skin on his upper eyelid. So you basically do a blepharoplasty to remove extra skin from the upper lids and use those skin grafts to cover the rest of the defect. So this worked nicely for this patient. Now I'm going to show you just some of the types of grafts and implants that we use in oculoplastic surgery. We'll go through a few examples. I have a separate lecture, and I'll put that in the folder. You'll all have access to it. I have a separate lecture that's a 1-hour lecture just on grafts and implants and oculoplastic and orbital surgery. But I'm going to show you a few examples from that. And the most common would be skin grafts. When we do a medial canthal lesion, usually a skin graft is a good way to repair that. There are other types of autologous grafts in addition to skin grafts. There's fascia, periosteum, cartilage, bone, and other types of so-called processed allografts or xenografts. These are tissue from donor tissue that has been processed. The processing can kill any type of virus, so they're safe to use. And there are many, many different tissues that have been used for reconstructive procedures in the eye and eyelids. And I'll go through a few of these examples just to show you. And this was a subtotal exenteration that I did for a very invasive squamous cell carcinoma involving the orbit and the eyeball. The eyelid was fused to the eyeball and tumor was growing through the sclera, so this eye was not salvageable. Now there are different types of exenteration. The classic original exenteration is just making a skin excision around the entire circumference of the orbit and removing everything. The difficulty with that is you have a bony hole in the skull that takes up to 2 years to epithelialize, and they can get drainage through the sinuses, and it can be difficult to manage. If you have enough normal skin remaining on the upper and lower lids, you can do what's called a subtotal exenteration, where you still remove all the eye and the muscles and most of the fat. You just leave a very small amount of fat and muscle at the very apex of the orbit. And that generates granulation tissue and vascularity and accelerates healing. And it allows you to close the skin of the upper lid to the skin of the lower lid so you can completely close all that together. I'm going to show you some lid trauma examples. Now, when a patient just has a laceration, simple laceration, they just require closure of the skin or sometimes skin and muscle. Be careful not to close it too tightly, or you could create an ectropion or a lid retraction. And if it's medial eyelid, always check for a canalicular lacrimal injury. When it's full thickness, again, if it's medial, often they will have a lacrimal canalicular injury, sometimes upper and lower lids. And you always want to probe the lacrimal canaliculus to see if it's injured. Now, if they've had a little bit of tissue loss, you might need to do a canthalolysis in order to be able to put it all back together again. This was a patient I saw during my fellowship in oculoplastic surgery. There's a type of dog in the United States, a breed of dog called pit bull. They're very popular. And they make good pets if they're treated well. But if they're treated badly by the owner, they can be very aggressive and very dangerous. And the grandmother of this child had a pit bull, and the child got too close to the dog's feeding bowl, and the dog attacked the child. And it took 4 adults to pull the dog off and open the mouth to get the dog off the child. And this child came into a children's hospital, and I spent 4 or 5 hours putting the eyelids back together, and 2 plastic surgeons worked on the gums and the mouth and the nose. But the whole midface was just loose and looking up. So we spent a lot of time putting this kid back together. She had a little bit of a web and a little bit of a superficial ectropion, so I went in later and did a secondary surgery. But in the end, she turned out pretty well for having such extensive injuries. This patient was a hospital worker. She came home one night and did not realize that her husband had paranoid schizophrenia, but he jumped out of the darkness and attacked her and bit her eyelids off. And she came in and almost her entire upper lid and the lateral canthus and some of the subcutaneous fat and about 2/3 of the lower lid she brought in a paper cup. And I was in my fellowship at the time, And sometimes it's good to be a little naive, because I was naive enough to think, I'm just going to trim the fat off of this, and I'm going to sew it right back into place. And some doctors told me that'll never work, there's no way it can survive. But I felt it was worth a try, so I took the fat off of this, thinned it down to where it was basically a skin graft and a tarsal graft, and I sutured it all back into place, and it did survive. It was dark and dusty and edematous for a while, but eventually it became vascularized. She did develop some upper lid cicatricial entropion, and I had to do a procedure for that, but all the tissue did survive. When we do lid trauma with canalicular injuries, we have to intubate the canalicular laceration and then close the deep tissues and then close the skin. We usually want to use a monocanalicular stent if it's just one lid, or a double canalicular stent if you need to intubate both of them. And these patients do well if you can intubate the lacrimal laceration. And there are different types of stents. There are the rocket tubes that we're all familiar with. There are also the Minoka stents, which are monocanalicular. They have a pumpkin plug. You can put the stent down into the canaliculus, and the pumpkin plug holds it in place in the pumpkin. We're going to talk a little bit about other types of lid conditions, such as entropion and ectropion. There are many types of surgeries that can be done for entropion. The simplest is a Quickert suture, where you pass a full thickness suture through the eyelid and you tie it tightly to evert the lid margin. This is considered a temporary repair because the entropion will often recur after a simple Quickert suture is placed. So this can be done in a patient that's too ill or too elderly to undergo a major procedure, and it can sometimes be sufficient to keep their eyelid from scratching their eye. In involutional entropion, there is horizontal laxity, there is disinsertion of the lower lid retractor. That disinsertion of the lower lid retractor allows the lid margin to either turn in or turn out. So really there's similar mechanisms for involutional entropion and involutional ectropion. And with these patients, you will see kind of a rolled edge just below the lashes. That's the pretarsal orbicularis layer rolling upward. And when that contracts, it's a force that allows it to turn the eyelid margin inward. And over the years, there have been over 100 procedures developed for entropion repair. But nowadays, a few of them are most commonly used. I often do a lateral tarsal strip to address the horizontal laxity when I'm treating either entropion or ectropion, where you make a lateral canthal incision, you do a cantholysis, you split the eyelid into anterior posterior lamella, you create a tarsal strip from the tarsus, and then you attach that tarsal strip to the internal aspect of the periosteum of the lateral orbital rim. You want to make sure you go to the internal aspect. If you go to the external aspect, that pulls the eyelid away from the eye and will have a gap between their eyelid and their eyeball. You want to really go to the internal aspect, internal surface of the lateral orbital rim. And you can adjust how tight it is at the time of the surgery by how long the tarsal strip is. So you might have, if you don't get enough tightness, you can shorten the tarsal strip and do it again. But once that is in place, then you can close up your lateral canthal incision. It's a pretty easy, simple procedure. This is another simple procedure called a Weiss procedure. This is an older technique. It's not used as much nowadays, but it is effective if you have a combined mechanism entropion. Let's say they have horizontal laxity, but they also have some cicatricial component. This Weiss procedure, you make a full thickness incision all the way across the width of the eyelid, and then you put some internal sutures. They come out. They basically go in through the inferior fornix conjunctiva, then they go up through the eyelid, an orbicularis layer, and you tie it on the surface of the skin, and that creates an everting effect on the eyelid. So this can be very effective in a simple procedure for entropion as well. In some severe cases, I'll do a combined technique of lateral tarsal strip and make an incision all the way across the lower lid and look for the lower lid retractors. It's similar to doing a ptosis repair on the upper lid. You find the dehisced edge of the aponeurosis of the levator and you bring it back down and reattach it. Well, with the lower lid retractor repair, you look for that lower lid retractor that may have dehisced and you put in some internal sutures, perhaps micro sutures, and you attach it to the bottom edge